Thanks, Chris. Good evening, everybody. So apart from the fact that this is one of your talks that will earn you some ethics CPD points, I think it's an extremely important issue and a discussion which not enough of us are having with our families and with our patients. So what essentially are these end-of-life decisions and discussions? Just trying to, sorry. There we go. So essentially, end-of-life decisions comprise of palliative care, which you've already had a lecture on. And it's important to remember that palliative care does not mean no care. It means some kind of intervention that makes the patient comfortable, helps them deal with the diagnosis and helps them through that dying process. So whatever it takes, whether it's pain meds, fluid, medication that needed, spiritual support, and maybe some kind of alternative medicine as well. On the other hand, advanced, and they're not mutually exclusive. Palliative care is part of advanced care planning and end-of-life decisions, and deals more with death and bereavement, considers a holistic entity with a tripartite alliance, to use a political term, of the patient, the family, and the healthcare worker. And it's often a time for an honest communication and a difficult communication, which not all of us are comfortable having. And important to realize that we need to respect patients' dignity and their rights while they are competent to make decisions. And the important part of this are advanced directives. And we're going to go through these terms as we go through the talk. So what are the components of these end-of-life decisions? And we've all heard these terms bandied about, so I'm going to try and break them down a bit. Do not escalate treatment, or D&E orders, is essentially a decision to withhold one or more interventions. And these usually involve advanced management or life support measures. So for example, an intubation, a ventilation, should we put a patient on an inotrope to maintain circulation? Do we need to dialyze the patient, and do we need to do CPR? And particularly relevant in our COVID environment at the moment is, do we do CPR? Organ donation consideration. Again, not a topic that enough of us are comfortable having the discussion with, but we have an ethical responsibility to refer dying patients as potential organ donors. Just for clarification, with COVID at the moment, they're not considered as organ donors, but we'll deal with that a little bit later. We don't have to have that discussion on our own. There are expert teams in most of our facilities who can deal with this. Do not attempt resuscitation or DNR orders. Is essentially a deliberate act of withholding CPR. It must be clinically valid, consider the ethics and the law and the patient's wishes. And it's important before any DNR act is enforced that all reversible causes are treated. This entity is no longer advocated, and is essentially we're using D&E orders rather than DNR orders to manage these patients. Allowing a natural death or palliation, particularly in patients who with a terminal illness or chronic terminal care, where the patient needs to be comfortable and assisted through their dying process. So essentially it's a supportive care as compared to euthanasia, which is an active act of helping a person to die. And we all know that that's legally not allowed in the country, or in most countries. An advanced directive are orders or instructions that are the patient's wishes, which are made at a time when the patient is mentally competent and able to make those decisions on his own. These orders are usually known to a GP, a family, or the healthcare worker. And it's important because this assists us as healthcare workers to decide on what the future management of the patient is when they're unable to make those decisions. So why is this important, particularly in COVID? Most prediction models say that 2 to 10% of patients with COVID will die based on various risk factors. the majority of them feel that it's important to talk about end-of-life issues, but about only a third do. And again, the majority of people feel it's important to put these wishes in writing, but only a proportion of them do as well. So it's absolutely essential that we have the conversation, have it now, and make those things known, those decisions known to whoever the healthcare workers and the families are. So in this pandemic, why are end-of-life issues so important and relevant? The difficulty with the doctors especially is that we all taught to save life. From the get-go medical school and nurses, you get told you have to do everything to save a person's life, and you do whatever is necessary to do that. And we never really get taught on how to let people die. And it's probably a contradiction in terms, but absolutely essential. Often we won't take the futility of those interventions or the end outcomes beyond the intervention into account when we make these decisions. And most importantly, we don't take patients' wishes into account. What does the patient, or what would the patient have wanted? At a time of rapid deterioration, families often can't make those decisions because they're emotional, and the patient may not be able to do it themselves because they're not mentally competent or legally competent able to do so. Particularly in a pandemic or disaster situation, difficult decisions about doing the most for the most, the utilitarian principles, and deciding who to escalate for care is essentially based on limited resources rather than on medical issues. So that difficulty with learning to let people die is a difficult one for most of us to deal with. We're all aware that 2/3 of COVID deaths will occur in a hospital environment. And in this current situation, where for infection control purposes and for safety, most family and friends are not allowed to visit people who are in hospital. Sorry, it becomes a very lonely, challenging time, particularly for the patient, and especially if that patient is elderly and is confused and things like Alzheimer's. They don't have that reassurance of familiarity and family around them. And if you look at the two pictures at the bottom, that's essentially what our patients are being faced with. A very dehumanizing veil of a plastic mask, a gown, a mask, with very little or no human contact. And it takes away a lot of the personal support and comfort that the patient actually needs at this time. And a lot of these decisions that have to be made and the discussions that have to be made are done telephonically. Sometimes with modern technology, with a FaceTime, where a family member can chat to the patient. But the vast majority, phone and say to the family, your loved one is deteriorating or is not doing well. And that is based on the fact of whether the healthcare worker actually has the time to do that. Many units have made that an essential component to give family feedback, but it's not always possible. So who are the patients most at risk? Prof. Bloomberg discussed this last night. Obviously the elderly, and again, as I said, for the elderly patient, who there's the risk that there's Alzheimer's, mental confusion on board, with that already providing an anxiety-provoking situation. Obviously, our more obese patients, uncontrolled diabetes and hypertension. It's important to remember that diabetics and hypertensive per se, well controlled, are generally not as at risk as compared to patients who are uncontrolled. Our frontline healthcare workers, people who live in nursing homes or institutions, our mental health care patients, patients with chronic diseases, heart disease and kidney disease. And while everyone needs to have these end-of-life decision conversations, most of us don't. And often when it's at the time of the patient being critically ill, that's when we decide, okay, we need to do something about it. And it's often too late to have that discussion then. So for healthcare workers, as we take stock of beds, gloves, numbers of ventilators, we must also be ready to dig deep into our reserves of patience, communication, compassion, and empathy. And as we learn to let our patients die with dignity. And for most of us, as I said earlier, this is a very difficult thing to do. We are supposed to be saving this person's life. How do we accept that we're not going to intervene, or we're not going to actively do something to save that life? So what are the key issues in making these end-of-life decisions? Important to know, and we don't always do, whether there's an advance directive, and as I said, is the healthcare worker aware of it? If the patient is unable to make those decisions, is there a designated proxy? So is there someone that has been appointed by a court of law to act on that patient's behalf and in their best interests? Obviously, we need to communicate with an identified member of family if the patient's unable to make those decisions. And important that there are legal and ethical issues, and we'll talk a bit about those issues later in the talk. And the concept of a good death is almost paradoxical. What does it entail? And in interviewing people, the common things that have come up is dying at home, having family or loved ones around them, and not having pain and suffering. And those sound simple enough, but often it's very difficult. We're in an environment where patients are in a hospital. They're in this environment alone. There's not often a healthcare worker near them, so that human touch and support is not always available. How much communication happens? Sorry, and is there spiritual support? For a lot of people, that spiritual or religious support is what gets them through. And again, as I said, there's no real family contact. And acting on these issues involves the healthcare worker, the patient, and the family. And it's important that those joint decisions are taken in discussion with all three. The communication about end-of-life issues is a process of communication rather than a legal entity. And as I said, often an uncomfortable discussion, more for the healthcare worker than for anyone else. And it's essential to plan for future medical care, and allows that any care that then ensure is occurring then matches what the patient's values and wishes are. The two main components of this are living will, which are essentially decisions made about a future treatment while the patient is alive, and appointing a healthcare proxy so that when I'm not able to, someone else can make the decisions in my best interest. And this doesn't only mean that an elderly person has this. A young 20-year-old male, for example, who's in a motorbike accident and is placed on a ventilator will need a proxy, will need a living will. So, don't make the mistake of believing that this is just an entity that needs to be discussed with the elderly. From the minute that the person is an adult or legally an adult, it's an essential entity as part of your planning, along with your insurance policies and your saving and your will and all that, to have this discussion. Obviously, cultural and religious beliefs come into it, particularly in terms of how people deal with dying. Some religions believe that, really religious people believe that it's a higher power or a God or an Allah that determines this. And, go with that if their faith is strong enough. So it contributes to how we will then deal with that, but we have to be aware of that. Alternative medicine, particularly in palliation, is important. Herbal supplements, acupuncture, things like that are important and can give some modicum of comfort to the patient. Misconceptions about death and dying are critical in this discussion. You'll often hear people will say, well, it's too depressing. It might push the person into suicidal ideation. I feel I'm abandoning my patient if I have this discussion because I'm not doing what I'm supposed to do. So difficult more discomfort for us to have these discussions. As I said, the doctors will come up with excuses, essentially, to say, it's an uncomfortable decision. I don't have enough time to do this. I've got too many patients to see. It gives me a hopeless scenario, and in a way admits my failing as a doctor, because I can't cure this patient and I can't provide medical care that's going to be of a positive outcome. And I think we need to understand is that death is not necessarily a negative outcome in this situation. That, the belief that death has relieved a patient's pain and suffering and has eased that patient, rather than thinking about it from our own point of view. Patient barriers are also, and family barriers are just as important. Patients in denial about a diagnosis, as will be a family. My family member is not dying. They don't have a terminal illness, and there must be something more that can still be done. And those concerns and decisions have to be addressed and worked through. And I'll give you a very brief way of how to deal with that kind of situation and what to work through. It's important to give patients hope, and families hope, even in a negative environment. And we perceive death as a negative very often, and it doesn't necessarily have to be so. Patients' wishes about I don't want to be put on life support. I want to die at home. I'd like my family around me. I'd like my priest or my religious or spiritual leader around me. I would like to have forgiveness and make peace with families and issues that have been long-standing. Obviously, financial and legal papers to be in order. And one of the most important things that people often say is, I don't want to suffer and I don't want to have pain. And particularly for elderly patients, that I want to retain my dignity. And often in this COVID situation, there's a rapid deterioration. There's not always time to have these advanced, prolonged discussions. So having an advanced directive ensures that your wishes are then fulfilled. So I said I'd go through a very brief way of how to broach that subject, because I think we often need tools on how we deal with the situation. And this red map, a 6-step approach to the conversation about planning of care or end-of-life decisions, was devised in Scotland fairly recently, and more specifically about COVID, so that they could have the discussion, because as we know, the pandemic affected the UK particularly badly in terms of their elderly population and the patients that were dying and that couldn't always have access to the resources. So are we ready, especially in terms of the patient? Not necessarily are we as the healthcare workers ready, but is the patient ready or the family ready to have this discussion? Introduce that topic. What do they understand by coronavirus? What do they understand about the outcomes? What will they do if that happens to them? Expectations. What do you know and what might happen? Your questions, the worries and concerns. Do you have a proxy? Is there someone that will make decisions on your behalf? And then the diagnosis. What do we know? The facts. What are the pain management? What are the medical management alternatives? What would happen? Would you be able to go home on home oxygen, for example? Is there someone that would be able to care? And more, even in South Africa at the moment, there's a move that, knowing that there are resources that are scarce and that I may need oxygen, and there may be a shortage of oxygen points, or there may be a shortage of a bed. Would I be able to be managed at home, and what would that entail? What other matters are there? Issues affecting the patient and the family. What are your likes, and what do you want to happen or not happen? What actions can be taken and what can be done to help? Are there options? Is there hospice? Is there home-based care? How will the family cope? Are they able to isolate you at home? and what are the plans for treatment. So, it's a very simple way of going through this, particularly for your notes and for people who are dealing with patients not necessarily in a hospital situation, to go through this 6-step plan and basically just document, that there's some documentation that when the patient was medically competent, this is what their wishes were. Just an aside is who can be that proxy for the patient. And it's important to know that when a patient is unable to have that decision-making capacity, that a surrogate or proxy is designated, and this is a legal entity. It's mandated in writing at the time when the patient has medical competence, and it's a court of law order. So it's important that this is understood to be a legal issue where the patient is of mental soundness to make decisions. They can understand the information, they comprehend it, and as I said, it's a legal document, as opposed to capacity, which is essentially what the doctor assesses the patient's ability is to make an informed decision. And in order to appoint a proxy, the competence is the key issue. And in order of descending importance, or in order of descending legal standing, the patient's spouse or partner is the most important, followed by a parent, a grandparent, an adult child, and a sibling. The patient, we've often joked about the fact that the patient's spouse or partner is the first person to make decisions, particularly if they're big life policies in which the beneficiary comes into it. Again, all these people need to be medically competent or legally competent in order to be a proxy. In an emergency situation, often we don't know, and where life interventions need to be made, often the head of the healthcare establishment in which the patient is brought to can act as a proxy, and an emergency court order can be sought. So, for example, a child whose parents are Jehovah's Witness, who needs urgent care, and the doctor feels that it's absolutely essential to intervene in terms of a transfusion or something similar, could be overridden with a court order and dealt with at a later situation. And it's important, furthermore, that a proxy in an emergency situation or in any kind of healthcare situation, that proxy then gets all decisions involving the patient's management or queries regarding that are discussed with the proxy. So this entire discussion is bound by ethical and legal frameworks, and in South Africa, that is essentially, we are guided by the Health Professional Council and the laws of the country. Laws essentially are the National Health Act, the Bill of Rights, and the Patients' Rights Charter, which govern access to care, the dignity of the patient, what information is discussed with the patient, and the patient's right to refuse any kind of further treatment, provided they are mentally competent. The HPCSA guideline booklet 7 deals with withholding and withdrawing treatment and provides a very good guideline in terms of what healthcare workers need to know about withdrawing treatment if it started, withholding treatment before it started, and particularly with life-prolonging or sustained treatment. And it should be done in consultation with the patient's advance directives, should they exist, and in consultation with a senior clinician or an expert in the area. So it can't be the junior MO or the very junior registrar making these decisions on the patient's behalf. So what should an advance directive include? And these are HPCSA guideline based. It should include the patient's wishes and preferences with regard to any kind of future treatment. It should include the values and beliefs of the patient. Obviously, family or surrogates or proxies that are appointed. Interventions considered if there's an emergency arising. For example, if CPR is needed, and particularly in COVID, for example, where CPR, is an aerosolizing procedure and a high-risk procedure, what do you do with that in that instance? What are the patient's preferred care of place of care? Do I want to be taken to a hospital? Do I want to remain at home knowing that my outcome is terminal and that there's no active intervention that's going to happen at a hospital? Obviously, the patient's need for religious, spiritual, or other personal care, and this again will entail some kind of alternative medicine should that be requested. If there are no advanced directives or the patient is incapacitated, and more often than not, particularly in our emergency departments, this is what we're faced with. Patient arrives terminally ill, what do we do? And the doctor has to consider the available treatment available, any previous requests from the patient while they were mentally competent. So if there's a family member who comes in and says, my dad said that he does not want to be put on any kind of advanced life support, and there are people that can corroborate that information, that does play a role. What is known from previous treatments or background, has some kind of discussion happened or with a GP, with a healthcare worker previously? What are those patients' values, beliefs, and preferences? And this again will all be from third party or family who are with the patient. And what is the best option of treatment if more than one is available, and for that patient, particularly at that point in time? And important to have the patient's best interests at heart, and most importantly, not to do anything illegal. So obviously the instances where family or people who are proxies or who are related to the patient in some way would come in, particularly if they stand to gain financially. So you have to be very aware of these things. And one of the most important things in this environment or in this instance is to make sure that clear, concise notes are documented at all times, just to protect yourselves. As I said, in an emergency where there's life-threatening situations, and any delay of not intervening may prejudice the outcome of the patient, the doctor then treats the patient, does whatever necessary intervention is necessary to save that patient's life, and obviously then further interventions or de-escalations can happen once more information is available and in conjunction with a discussion with the proxy at that time. It's important to inform the patient or the surrogate, obviously, as soon as you are able, and withdraw the treatment as necessary in accordance with the patient's wishes as that happens. In a pandemic situation, what happens when and the HPCSA guidelines give guidance on this to say that treatment can be withheld due to a scarcity of resources. And, it's not just a pandemic. We do this on a daily basis. The young 20-year-old involved in the MVA who's on a ventilator versus the elderly patient who's got terminal cancer who gets the ICU bed. That's essentially what this is withholding treatment because of scarcity of resources. In America or in the UK, for example, under normal circumstances, every patient who needs an ICU bed will get it. But it's not always possible. How many patients have access to dialysis? And we've had court cases in South Africa where this has been an issue. Neonatal ICU. So where there's limited resources and specialized units generally, that need and that shortage is escalated in a disaster or pandemic situation. Obviously, the choice of who gets the ICU bed with two similar patients of similar age and similar risk, becomes an ethical discussion. And it's important that if we are in the situation where we are withholding this, what are we providing as palliation, and what are we saying is an alternative source of treatment for that patient? So it's not just, we don't have an ICU bed, so go home and that's it. So I think it's important that we and again, especially with these instances, that we document notes adequately to ensure that, we've had the discussion. This is what we are offering. This is what the alternative is. And often, it may not be an ICU bed in your own facility or where the patient is. It may be having an ICU bed in another facility. And we're doing a lot of that at the moment, particularly where our ICUs and high cares are full. So how has COVID affected all these issues of end of life and that discussion? The challenge is that COVID is a continuously changing entity. We don't know everything there is to know about the virus and the infection. So informed decisions are difficult. I mean, if we don't know the information, how do we give it to our patients? And standard guidelines are changing all the time, sometimes on a daily basis. So very difficult to have that informed discussion with the patient if we don't have the information ourselves. Comorbidities now more than ever are affecting outcomes negatively. So, do we disadvantage all patients with hypertension and diabetes? Or, do we judge each case as it on its merits? The resource shortages are worldwide, more so in our lower and middle income countries. And if we're looking at average figures, 5 to 10% of patients, sometimes up to 20% in our northern hemisphere, will require ventilation. Obviously, that is significantly decreased as we've understood the infection with time. So shortages of beds, ventilators, PPE, oxygen, healthcare worker shortages themselves inform decisions about whether further treatment is provided rather than just the medical principles or advanced directives. And rapid changes in patient conditions in hospital often leave no time for consultation or discussion, both with the patient or with the family. And it's absolutely essential that we have any ethical clinical teams in all our hospitals to assist with this decision making on whether care is escalated or not. It's also led to a situation where ethical principles have been challenged. Our normal principles of beneficence and doing good for the patient. We're not necessarily doing that good in this pandemic situation, because as I said, where you have a patient who under normal circumstances would have been put on a ventilator, your diabetic hypertensive patient who needs airway protection is not getting it now. So how much autonomy is there if resources determine care? Do I have the right as a patient to make a decision about my care and saying, I want to be placed, and advanced directives are not always about de-escalating care. It's also about saying, well, if I'm in that situation, I want whatever needs to be done to be done. That's an advanced directive. And how much autonomy are you giving me as a patient to make that choice? And then, as I said, the whole utilitarianism concept of doing the greatest good for the greatest number. We're not really doing that under these circumstances. A strange concept is reverse triage. Under normal triage, we triage the most critically ill patient gets prioritized. With reverse triage, we're saying the patient most likely to survive is prioritized. So it's your potential for survival and the outcome that's more important than your current clinical condition. Things like surge capacity, where we're increasing rapidly capacity, but we're not necessarily increasing the level of care and the potential for full treatment. Things like frailty scores on admission are being used, where older patients with higher frailty scores have a worse outcome and are generally not escalated. So again, taking away that autonomy and the principles of beneficence. Obviously, things like the quality of life post the intervention, post ICU syndrome in patients who are put on a ventilator, especially in older patients, are reality. So we need to consider those as well. So how do we work this whole entity into our planning? We all have disaster plans. We all have training on disaster medicine. And one of the critical things that need to be worked into our disaster plan is a palliative pandemic plan, where large-scale end-of-life issues are discussed and planned for. And this needs to be done as a standard. We often talk about, treating critically ill patients. So we stockpile equipment, we stockpile PPE, we have designated areas for triage, we have designated areas for dead bodies, all those kinds of things, but we don't often have a palliative plan. And for de-escalation, even where a patient under normal circumstances would have been treated. So this is important, especially outside critical care units. And it doesn't have to be in the hospital, it can be away from the hospital. So what is needed for this palliative plan? Obviously, you need stuff, you need equipment and palliative meds and drips and things like that. You need staff. And in our environment, particularly, palliative healthcare workers and counselors are a scarce resource. So do we have enough people with expertise? Can we pull from, for example, GP practices or, public-private partnerships where NGOs can provide some kind of assistance in grief counseling? Do we have a designated space? As I said, often in our hospitals, we have areas that we've designated, meeting points and areas for specific things. But palliation and de-escalation of care of patients is often not a priority. So, and as I said, it doesn't have to be in the hospital. It can be in areas, for example, like hospice, who are trained, people have been trained to deal with this and provide that kind of support. And do we have systems in place? Are we ensuring that advanced care plans are in place? Are we having those discussions before that with patients and their families? Obviously, community discussions and provider networks are important in providing that kind of systemic support. Despite all this, pandemic and disaster situations challenge healthcare systems and processes to their maximum. Rapid bed turnover, shortages of everything, beds, equipment, staff, PPE, and even time is a critical issue. So, in order to mitigate those or to supplement those difficulties, if we have the plan in place, it does make a difference. And finally, when a patient's medical diagnosis precludes the hope of health being restored or maintained, and the death of a patient is inevitable, the physician and the patient are often faced with a complex set of decisions regarding medical interventions. Advances in medical science have improved the ability of physicians to address many issues associated with end-of-life care. However, it is the area of medicine that historically has not received the attention it deserves. And while the priority of research to cure disease should not be compromised, more attention must be paid to developing palliative treatments and improving the ability of physicians to assess and address the medical and psychological components of symptoms in terminal illness. Most importantly, the dying phase must be recognized and respected as an important part of a person's life. Thank you very much. Chris, I think I don't know if there are questions through you.
Sure, yes, there are a few. Thank you so much for that. So there's a bit of echo coming through. The first question we have is same as a living will.
Chris, I've lost you.
Hi, Prof, can you hear me now?
And I can hear you.
So the first question was, is an advanced directive the same as a living will?
So not necessarily. An advanced directive is simply providing guidance in terms of what your wishes will be, should I not be competent to make a decision. A living will is saying, what do I want to happen? Do I want advanced life support? Do I want to be put on a ventilator? Do I not want to, if I'm in a situation, not to be put on a ventilator? So a living will is specifically saying what you want to happen. Do I want my body to be, not related to any further interventions or active CPR, for example? So there is a slight distinction. The living will is part of end of life directives. It's one of the components of it.
Thank you, Prof. The second question, which Mandy did address, but I thought maybe it might be good to verbalize it, is what are the guidelines regarding organ donations during this time?
Right. So I actually phoned her this afternoon to clarify that. So because it's like when we first had HIV. Everything was a no-no until we found out a bit more, and things were allowed. The same with COVID. We don't know enough to say that we will use COVID positive patients as organ donors. So for now, it's no.
Perfect. Thanks, Prof. You made mention of embryos that can assist with palliation. Do you have any specific references that people can maybe refer to?
I'll post it's on. You recorded the talk. Hey, it's on the last slide of the talk.
Oh, was it there? Okay.
Yeah, it's on the references are on the last slide of the. If I can just put it up, let me just try and get it.
I see Mandy hit PELPRAC.
Yes. Just try. Sorry, I'm trying to get the. I can't scroll down, but it's on the slides, and I'm happy for the slides to be shared.
Okay, perfect. Thank you, Prof. There's another question as well.
There we go. Yes, I'm listening.
Regarding physiotherapy as part of palliation or end-of-life care.
Yeah, so obviously all those physio, OT, any allied support is part of that whole palliation team. I think it's important, particularly with physio, if you've got a bedridden, terminally ill patient, essential to have that kind of, so essentially anything that will make the patient more comfortable is essential. Okay.
Perfect. Thanks, Prof. Mandy, you should be able to unmute now. Can you?
Yeah, thank you, Chris. Just with regards to transplant, I just want to make it clear that we are still doing organ donors, as long as they're COVID negative. So please phone the coordinator, allow us to assess the patient, and then obviously remember that a patient that has been COVID positive for more than 8 to 14 days, probably COVID negative. So allow the transplant team to make that decision as to whether that donor can go ahead, because often what happens, we ventilate them in a COVID ICU for 3 weeks, but they're COVID negative by then. So we need to also make that assessment, and we will do
Absolutely.
that. If they're COVID negative, we will use them. We will be very valuable to ensure that we can do a transplant. Yeah.
Absolutely.
Thanks, Mandy. That's a very good point. I see Rich has also posted a number here for the COVID-19 counselors in Gauteng. Juanita Kruger, and he had that number as a free service. Are there any other questions or comments from the audience? Feel free to raise your hand or type them into the chat. I'll give it a few seconds. Just as a reminder, just to everybody, that the talks are all recorded and available online. They're on the Netcare YouTube page. And our plan is that we'll continue with daily talks at least for every weekday up to the end of July. And then we'll still plan out the schedule for August, but we'll hopefully, or not hopefully, we'll likely switch to twice a week during August, depending on how the demand goes and the need for these lectures. But at the very least, the recordings are available online. Prof, I don't see any other questions, so perhaps we can close it off there for tonight.
Okay. Thank you very much.
Perfect. Thank you very much for your time, and thank you everybody for joining us again, and we will see you tomorrow night. Mandy, a reminder of the talk for tomorrow night. It's I think it's David Stanton, if I'm not mistaken. It's a kind of a practical demo on how to do this. I think that's what it said, how to do this for COVID. So it's a bit of a practical demo on intubation and ventilation. So it should be a very...
Sorry, Chris, I couldn't unmute myself, but I think we've actually changed tomorrow night to the second episode of the nursing scenario. But I don't have it with me because I'm not actually at my base unit. So I think tomorrow night is the next nursing intervention.
Okay, perfect.
And
thanks so much.
What is planned for the rest is also interesting. We're going to have something on pediatrics and COVID. And obviously we're going to have that practical session with Dave, but we've moved that a little bit later.
Perfect. Thanks so much, Mandy. So we are busy trying to set up a website, a Netcare website, where all the information will be available. Just keep you have an easy reference to the schedule as it changes. And we will share that as soon as it's set up. Just making a few minor design tweaks to today, and we'll hopefully have that ready for you by tomorrow. But the recordings, as I mentioned, are on the Netcare YouTube page. Okay, thank you, everybody. Thank you again, Prof, so much for tonight. And
thank you for having me. Thank you.
Thank you. Good night.
Night.